Today, I'm going to talk about risk reduction and mitigation in office-based anesthesia. And I do not have any disclosures. I have 3 learning objectives today: to understand the risk factors for adverse events, understand the strategies that are necessary to mitigate our risk, and to understand the importance of teamwork. New York State has an office-based surgery law, which was last revised in 2016. And what it says is that any surgical or other invasive procedure requiring general anesthesia, moderate sedation, or deep sedation, as well as any liposuction of more than a half a liter, can be performed in a location other than a hospital. Now, it's important to recognize that this law does not include dentists. It does not include anxiolysis and minimal sedation. It does not include local. It does not include minor procedures that are done under minimal sedation. However, adverse events, according to this law, must be reported within 72 hours. So what kind of procedures are done in the office in the state of New York? New York State, just so that you know, is one of the largest, greatest volumes for office-based anesthesia in the United States. So what kind of procedures are being done? Upper and lower endoscopies, rhinoplasties, mammoplasties, lithotripsy, access, vascular access, even major vascular access, upper as well as lower extremity nerve blocks, neuraxial anesthesia, and all of these procedures can be done, as already mentioned, with moderate and deep sedation, as well as with general anesthesia. Now, office-based anesthesia is a moneymaker, can be a moneymaker. And this was published in USA Today in 2018. How a push to cut costs and boost profits at surgery centers led to a trail of death. And it described the first surgery center in the United States, which actually opened in 1970, not that very long ago. And it was a place that was squeezed between neighborhood shops and a Baptist church, where for $90, a child could receive an incision to relieve pressure on the inner ear. The pioneering doctors, Dr. Ford and Dr. Reed, decided to open this surgery center because they didn't see why patients needed to be hospitalized for such major surgeries. When we think of office-based anesthesia, we think of a variety of locations. This is a pediatric dental office, which is trying to attract the children as well as the parents. It looks like a fun place. And you can have such extreme locations such as this. This was Michael Jackson's bedroom, where he received his final doses of propofol. Office-based anesthesia can be dangerous. And there are, if you look in the media, many reports, particularly of children who die under sedation or under anesthesia in the pediatric dental chair. Here we have a 3-year-old, this was just recently over the summer, who dies after a dental procedure. And then we have another boy here, again, who died after a dental procedure. And this was published a while ago, but it says that looking at all the media reports, that dental sedation was responsible for at least 31 pediatric deaths over the course of 15 years. And I would say that this is an underestimation because so many of these events are open and shut closed cases, and we never hear about them. So let's start thinking about how we can make our office-based anesthesia safer. And I want to first start thinking about children, and then we'll start thinking about the adults. So in 2017, the Society of Ambulatory Anesthesia registry was harvested for 4 years worth of data. And it was data of just the dental anesthesiologists. And as you know, dental anesthesia is now its own recognized specialty by the American Society of Anesthesia. They looked at 7,000 cases of pediatric dental patients who underwent both sedation and anesthesia. The majority were healthy and under 6 years of age. There were no significant events reported. Now, you need to remember that this SAMBA registry, however, is self-selected. The practitioners decide if they're going to participate and which data they're going to contribute. So I like to think about the ABCs of office-based safety. Avoid trouble, be ready for trouble, and think about a culture of safety. Originally in 1999, the ASA established guidelines for office-based anesthesia, and they have been revised many times. The latest revision was in 2019, just a couple of years ago. And I'd like to highlight some of the most salient aspects of this. And that would be patient and procedure selection. The anesthesiologist should be satisfied that the procedure is within the scope of practice of the healthcare practitioners and the capabilities of the facility. And I think that is very important. In addition, the procedure should be of a duration and a degree of complexity that will permit the patient to recover and be discharged from the facility. Patients who, because of pre-existing medical conditions, might be at an undue risk for complications should not be cared for in the office-based facility. They should be referred to an appropriate facility. And I think these are three very important points. I often say if you want to be safe, you need to choose your patient wisely and avoid those patients and procedures that are going to pose problems. Now, we need to think about, especially in the adults, which patients, especially now, we think about obstructive sleep apnea, we think about the problems with obesity in our country. We need to think about what are the predictors that our patients could get into trouble to have respiratory decompensation, oxygen desaturation at home after discharge. This study looked at patients for up to 48 hours after they were discharged home with a pulse oximeter. And they looked at what were the predictors of at-home oxygen desaturation within those first 48 hours. And what did they find? A high body mass index, a high stop baying score, those patients who are older, those patients who are on home CPAP, and those patients who had received opiates. These were all indicators of oxygen desaturations. However, it's important to recognize that the home CPAP and, interestingly enough, the opiate use actually decreased the number of oxygen desaturations as well as the duration of oxygen desaturations that was seen in this adult population. That's very interesting. But certainly when you have patients who are on CPAP and you discharge them home, it's important to remind them that they need to be using their CPAP. This study looked at the respiratory complications postoperatively for those who are at risk of obstructive sleep apnea. This was from a single institution. It was a retrospective study of over 100,000 patients, looking to see if there was some way that they could predict those patients who were at risk for having apnea. And they did. They found that there was a scoring system, and I'll tell you what were the indicators for that score. But those patients who scored higher on the PSAP score, which means perioperative sleep apnea prediction, those patients who scored higher had over a 2-time increased risk of having problems after intubation. So what are the indicators that feed into this score? As I already mentioned, high body mass index, actually greater than 30, snoring, hypertension, diabetes, Mallampati 3 or 4 on airway exam, those patients with a thick neck, and those patients with a short thyromental distance. Let's now turn ourselves and look at frailty. Patient frailty has been recently examined as a serious indicator and predictor of morbidity following even the most common ambulatory surgical procedures. Frailty can increase your risk of post-op complications up to 30 days. When they looked at those 100,000 patients, they found that those patients, even those less than age 40, who scored intermediate to high on the modified frailty index, were at a greater risk and up to a 3-time greater risk of having complications. What are these frailty traits that we need to look for? Diabetes, an impaired functional status, history of chronic obstructive pulmonary disease or pneumonia, history of congestive heart failure, history of myocardial infarction within the last 6 months, history of percutaneous coronary interventions. There's more. Cardiac surgery, history of cardiac surgery or angina, those patients who are on antihypertensives, who have peripheral vascular disease, even at rest, those who have an impaired sensorium, those with dementia, for example, delirium, and those who have a history of transient ischemic attacks or cerebral vascular accidents who still have persistent residual deficits. These are all important traits that increase the frailty index and increase the risk of having post-op complications. So, A, how to avoid trouble? Well, how to avoid trouble is to think about all these medical conditions that I've introduced you to when you evaluate your patient, and give careful consideration to whether or not these patients are suitable for your office-based procedure. Number B, be ready for trouble. Lucien Leap at Harvard in 1994 said, "Error is inevitable, even among conscientious professionals with high standards. Errors reflect systems and not character flaws." And I think that's so important. Be ready means also we need to be ready to be able to identify when we've made a mistake, to identify the near misses, and to be ready not only to make changes, to do a conscientious and thoughtful evaluation, and then to think through how we can make things better in the future. If you look at these office-based anesthesia guidelines, the ones that were updated in 2019, they have specific referrals to the be ready, as I said, specifically referring to emergencies and transfers from the ambulatory surgical office-based location. What do they say? They say that all facility personnel should be appropriately trained in and regularly review the facility's written emergency protocols. The written protocols for cardiopulmonary emergencies and other internal and external disasters such as fire should also be included, okay? All facility personnel, all of them, including the receptionists, should be trained and knowledgeable about what their role would be in such an emergency. The facility should have medications, equipment, and written protocols to treat malignant hyperthermia when triggering agents are used. This is very important. It's a very common question, whether or not these facilities should have the necessary medications for malignant hyperthermia. And they should if a triggering agent is going to be used. There should also be a written protocol for the safe and timely transfer of patients to a pre-specified alternate care facility when extended or emergency services are needed. Okay? This is very important. You need to know where your closest emergency facility is for your patients should they need to be evacuated. How could you be ready? Well, office-based simulation. This was published in the Journal of Oral Maxillofacial Surgery, looking specifically at the best way to perform simulation training in the office setting. And I really like this because it delineates the different roles of the different personnel. The doctor, the anesthesia assistant, should there be one, the surgical assistant, as well as the front office clerk. You can tailor these tasks to your own setting. But what's important is to recognize that everybody in the event of an emergency needs to know what their roles are. Now, I want to talk about C, a culture of safety. Massachusetts presented what they called the Promises Project. And this was a randomized trial designed to reduce ambulatory malpractice and improve safety. And it identified high-risk domains. It looked at 25 primary care practices, and it looked at their quality improvement initiatives that were taken over a year, 15 months actually. And how were these quality improvement initiatives done? They were done by webinars, face-to-face meetings, and coaching. And there was emphasis on establishing a culture of safety and teamwork. Now, you may say, well, this was primary care. What does this have to do with office-based anesthesia, surgery in our setting? But it does, because it's all transferable. What it found was that there were some domains that needed to be improved. Now, what were the domains that needed to be improved? The domains that needed to be improved was working on establishing a culture of safety and a culture of working together with increased communication and teamwork. And I think this is very important that we think about this, because when we're in such a small setting as an ambulatory setting or an office-based setting, everyone there is part of our team, and they all need to be involved and feel committed to patient safety. In 2011, the National Health Service in the United Kingdom published something that I found very interesting, and I think it's still applicable even now, even more so. And it looked at staff management and health service and the quality of it. And it looked at what were the predictors to staff medical provider turnover. And what it found was that staff engagement was a predictor of turnover. Those medical staff that were less engaged were more likely to leave. And what is staff engagement? Staff engagement reflects job satisfaction, the work pressure felt by the staff, the ability to have flexible working conditions, and to receive job-relevant training, learning, or development. And I think it's very important when we're thinking about our team and working together in a culture of safety, you want to engage and keep those team members that are valuable. And for that reason, you need to think about making sure that all your staff that you value remain engaged. And this isn't only looked at in the medical community. This was just published in October by CNBC, looking at the 10 companies that have the happiest employees and why? So the happiest were in Adobe. And why was that? Because they scored an A+ in their work culture, in the rating of their leadership, the CEO, in their perks and benefits, in their compensation score, and in their office culture score. Let's look at what are the leading causes of anesthesia-related liability claims in the ambulatory surgical center. Remember, 25% of all outpatient ambulatory procedures are done in an office-based setting. So it is relevant to look at the data from these ambulatory surgical centers. And if you look at 7 years of closed claims data for hospital and ambulatory centers, you find 994 anesthesia-related claims. And if you compare the claims for those related to the hospital-based setting to the ambulatory-based setting, you find that the claims in the ambulatory center have medium severity as compared to a higher severity in the hospital-based setting, and more claims related to pain. If you comparatively look at the hospital-based setting, you find that there's higher claims for death. In fact, 21% of all claims was related to death in the hospital setting versus only 11% in the ambulatory setting. They were related to respiratory arrest, there were claims related to organ failure, and cardiac arrest. So what are the most common anesthetic procedures that result in claims in the ambulatory center? A third of all claims were related to injection of anesthesia into a peripheral nerve. A third were related to an intubation. And interestingly enough, maybe not surprising, obesity was the most common contributing comorbidity in both settings. And the mean closed claim value was significantly lower for those who suffered in the ambulatory setting than those who suffered in the hospital-based setting by about $20,000. So what are the most common errors that we see in the ambulatory setting that we can take home to improve our care? They're technical errors. Assessment. Failure to adopt important clinical information, just respiratory problems, allergies, reactions to anesthetics, existing dental devices. 9% are related to inadequate patient monitoring. 9% who actually didn't have or had inadequate anesthesia-informed consent. So how can we improve our ability to make patient safety better? And what strategies can we use to decrease our liability? So, take-home messages. We can do better screening, better preoperative assessments, and better risk stratification of patients. We can be sure to incorporate routine dental and airway assessments into our documentation. We can be careful to diagnose, treat, and document perioperative pain adequately. And we can improve the efficacy of communication between patients and care providers. So with that, I would like to say thank you very much. This is one of my favorite quotes. Whenever I go on a ride, I'm always thinking of what's wrong with the thing and how can it be improved. And I think about Walt Disney's quote whenever I take care of a patient, because at the end of every case, we should step back and think to ourselves, Is there anything that I could have done to make it safer, to improve the patient's care, or to improve the patient's experience? And with that, thank you very much. And I hope to see all of you in person next year.